Hello, my name is Nima Tamrakar and today I will be presenting a brief presentation on pathophysiology and pharmacology of Hashimoto thyroiditis. As we know, Hashimoto thyroiditis is a common cause of hypothyroidism, that is an autoimmune disease which occurs when your thyroid gland becomes irritated or inflamed due to the number of reasons where the antibodies that your body makes attack the cell in the thyroid. Usually, white blood cells called T cells are able to distinguish between self and non-self in a functioning immune system. However, this is not the case in Hashimoto's. Helper T cells in particular get activated and begin to see thyroid antigen as foreign or danger, including thyroglobulin and thyroid peroxide (TPO). The exact reason of the circulating antibodies or breakdown of self-tolerance is unknown. Possibility may include abnormalities of regulatory T cells or exposure of normal sequestered thyroid antigens that become exposed. Again, HLA-DR3, HLA-4 mutation leads to alteration of immune function, which also result to undesirable antibodies of their own tissue. Other immune cells, including B cells, are then stimulated by these activated T cells to develop autoantibodies. Anti-thyroglobulin and anti-TPO directed against the thyroid-specific proteins. Similarly, interferon-gamma and tumor necrosis factor alpha are pro-inflammatory cytokines that are released by activated T cells, which worsen inflammation and draw additional immune cells to the thyroid gland. Then thyroid gland infiltration of lymphocytes and plasma cells is brought on by cytokines and other inflammatory mediators, resulting in chronic inflammation, which process lymphoid follicles that resemble those which are already found in lymph nodes. Now, the immune system then targets and eliminates the thyroid follicle cells, which are the actually make thyroglobulin binding with amino acid and iodine that's supposed to push in the bloodstream as the form of T3 and T4 with the thyroid follicles. When thyroid hormone production of the gland is hampered by this damage, resulting where T4 and T3 are not as synthesis with these damages to the follicles. Now, when thyroid follicle cells are lost due to the damage, fibrosis tissue takes place, known as fibrotic reaction, which is responsible for the hardness of goiter and the decrease in function of thyroid gland. So now glandular atrophy takes place as the final result of persistent inflammation and fibrosis, resulting in reduction in hormone production as the remaining thyroid tissue lost its function to carry on the duties. Over the time, the ongoing inflammatory process stimulates the proliferation of fibroblasts and the cell responsible for producing connective tissues, leading to accumulation of fibrous tissue, replacing functional thyroid tissue in that case. That results in decline of hormone production, which contribute hypothyroidism called Hashimoto thyroiditis. The body now attempts to compensate through several mechanisms. The pituitary gland sensing low levels of thyroid hormone and try to secrete more thyroid stimulating hormone, which increase the secretion of thyroid stimulation hormone called as TSH. That may elevate TSH level in the process, and elevated TSH level stimulated any remaining functional thyroid tissue in an attempt to increase hormone production. And in the process, the thyroid gland may occasionally enlarge in an effort to make up a low hormone level, result in goiter formation that in other words is called by hyperplasia inside the body. The hyperplasia of the follicle cells in response to increase the TSH in other words. Therefore, clinical manifestation presented in the patient for the same reason are fatigue, weight gain, hair fall, enlargement of the thyroid as goiter as presented in the case study. When the thyroid gland cannot create enough thyroid hormones 3,3 and 3,4 in people with Hashimoto thyroiditis, synthetic levothyroxine, which is one of the main in two primary hormones produced by the thyroid gland, is recommended as of the thyroid hormone replacement treatment. The drug class of it is called a thyroid hormone replacement. Brand name can be Synthroid, L-troxin, Levothyrox, and Oroxine. Once levothyroxine consumed and absorbed in the bloodstream and delivered to the tissue as transferred into thyroiduronine, that is T3, primarily in the liver and kidney. During that process, thyroid hormone receptor in the cell to regulate metabolism, speeding up organs on their function by boosting the synthesis and use of energy by promoting the metabolism of protein, lipids, and carb. Similarly, feedback mechanism from pituitary gland and hypothalamus plays the role by signaling to normalize TSH level for hormonal balance. Thus, levothyroxine helps restore normal physiological activities, which are slowed down in hypothyroidism and aids in battling fatigue. The doses and consistency must be considered for the patient with regular checkups and monitoring of thyroid function tests, including TSH and T3, T4 levels for any future modification, according to the patient need. Educate patient to look for any signs and symptoms and to make a regular checkup to monitor thyroid hormone level, along with the timing of taking the medication in the empty stomach is usually the consideration. Patient education must be knowledgeable so that they can aid and then modify their physical health along with the pharmacological aspect of thyroxine.